All right. Yeah. So you can take off.
No, it's okay. I'll monitor the chat for questions if you want.
No problem. Yes. All right. Assalamu alaikum, everybody. So let's continue with the last lecture of this part of the blog. So today we're going to be talking about cell death. Now, before cell death happens, I want you to keep in mind that actually before you see any kind of morphological changes, even by electron microscopy, which means looking at the ultrastructural changes that happen in the cell upon its death, you're not going to be seeing anything before actually the loss of cell function. So the first thing that will happen is going to be the loss of cell function. This is going to happen very shortly after, irreversible cell injury and cell death. Usually within a minute or two from hypoxia, you will see that the myocardial cells will cease to contract. That tells you that you have really very limited window in order to intervene and make sure that this kind of injury does not go into a reversible stage and then into cell death. So first thing that will happen, keep that in mind, is going to be the loss of cell function. Now, if that happened in that individual, actually, the person has survived that injury, what's going to happen? You will be able to see the spectrum of changes that we are looking at now. So you will be able to look at first at the electron microscope, and you are going to be seeing the ultrastructural changes, similar to what we have seen in a reversible cell injury, especially with regard to nuclear changes. Then, if that individual actually is still alive, be able to see those changes, with the light microscope. And then again, if this person lives enough and survived the initial insult, that he suffered, it may actually go all the way to be able to see the gross morphological changes that you will be able to see with the naked eye. Meaning, let's say that someone in a hospital setting suffered from a myocardial infarction, and the patient died immediately as a result of this myocardial infarction within, let's say, an hour or two. If you do an autopsy on that patient and you look at the heart, in your opinion, what you're going to be able to see? Any answer? Okay, well, someone say necrosis. Anything else? Cells without nuclei. Okay. All right. Just sorry about that. All right, so someone say necrosis, the other person said actually a loss of nuclei. Anything else? Any other takers? Go ahead.
Immunologic cells, BMNs,
neutrophils. Inflammatory cells. Yeah. Okay. Anything else? Actually, the answer to that is you will see if he dies within an hour or two, following myocardial infarction, you will see absolutely nothing when you do his autopsy. His heart will be clean. The reason for this is that he did not live long to actually show the changes that we are talking about. Of course, short of looking in the electron microscope, which never happens actually in a case of autopsy, but in the light microscopy and the gross morphology, there will be absolutely nothing, because that's gonna take some time. So the only thing that you really experience in this case is going to be what? The loss of cell function, right? That's resulted actually in the death of that patient. So why would, again, that's not, that part is part of your blog. What will you see in the heart? You will see absolutely nothing. Now, in your humble opinion, this is for later on. Why did the patient die if there is nothing in his heart? So he's sure he died as a result of ischemia and hypoxia, absolutely. But what is the cause, the underlying cause of death in this patient? Say again?
Free radical.
Free radical, sure, this is what we talked about. In reality, actually, this guy actually died as a result of arrhythmia, right? This is for later on, but just keep it in mind for the time being. All right, and related to this block. Now, how does the cell die? What are the ways, that the cell, could die with? The first one is going to be the necrosis. And the second one is going to be the apoptosis. Now, the way to think about it is actually necrosis is a chaotic way of death. It happens usually in the middle of war, if you will, in the middle of inflammation, and it is always pathological. Now, apoptosis, on the other hand, is a very organized, way to die. So if you think about it, it's like, it's something that has been set in motion a long time ago with regard to apoptosis. How does that happen? For example, when the cell reaches its senile stages, when it becomes really old, you will see that that cell is going to be killed or to be rid of using apoptosis. Okay, this is something to think about. So programmed kind of death when it comes to apoptosis. Of course, not just senile age is going to result in the death of the cell by apoptosis. There are other conditions where you see the cell is going to go through the apoptosis process and die. And those actually conditions could be either pathological or could be physiological, as opposed to what you see with necrosis, which is always pathological. Something to keep in mind, when you try to compare and contrast the two ways of death. Now, both of them are going to be dying as a result of enzymes. So both of them are actually enzymatic, cell death. With regard to the necrosis, the enzymes could come from the cell itself, or it could come actually from the inflammatory cells that will be wheeled to the site of action. Now, with apoptosis, the enzymes in this case is going to be in the form of caspases, innate, inner cell enzymes, inner cells, processes that are going to dismantle the cell one piece at a time, resulting in the apoptotic process. Right. So how would you tell if the cell is dead? Now actually we're talking about death by necrosis. If you look at the cell, and if the cell is too reddish, as we have spoken, yesterday, as I discussed with you yesterday, that's actually a sign that the cell, either dead or is going to die. The reason for this is that, before the cell die, you will see that the proteins in the cytoplasm will become coagulated, and they are going, and when you do the stain, the hematoxin and eosin stain, you will see that the eosin is going to bind up this coagulated, degraded proteins with higher affinity, and as a result of that, the redness of the stain is going to become accentuated. Not only this, in the cytoplasm itself, there are actually some nuclear material from the nucleus. Those components are going to die first before the proteins, die, before the proteins are degraded. So the first thing that will go away is going to be actually the nuclear material that are present in the cytoplasm. And usually the nuclear material will stain blue with hematoxylin. So now in the cell, in a cell that is dying, you are seeing actually that the blue is going away and the red is staying. And as a result of that, there will be further accentuation of the red of the cytoplasm. So the cytoplasm will become very red as a result, actually, of cell death. The second thing is that the cell, before it dies, it was actually strapped from oxygen as a way of dying as a result of hypoxia, for example. The end result of this is going to be that the cell is going to rely on the glycogen. It will break down its content of glycogen and glucose in the process of anaerobic glycolysis. And that is going to result actually in making the cell shrink in size, because it's going to break down its content of glycogen. And the nuclear changes that we have talked about yesterday. Right, so now, that cell deaths have happened. You have a mass of cells that are dead. Now, how these cells are going to actually organize, how they are going to, what are the different appearance that they are going to take, will decide what you are going to be calling them. And there is a list actually of morphologic appearance when it comes to necrosis, and that will make it actually a special form of necrosis. At the end of the day, the cell is dead, and the cell has ceased to exist, but again, the appearance will be different from one condition to the other. So the appearance of these mass of cells is going to depend on two processes. The first one, how the proteins have been degraded or not, that's number one. And number two is the digestion by enzymes. And we will see how that come to happen in a second. So starting with the coagulative necrosis. These are the different types. I hope to be able to cover most of it today. All right, so starting with coagulative necrosis. Now the process that happens here is that the cell has died. And the cell, before actually it died, it was resorting to anaerobic glycolysis. And lactic acid has accumulated in the cell. With lactic acid accumulation, what will happen to the pH? The pH will dip down, right? So there is acidity that has set in the cell. Now, this acidity is going to deactivate many of the enzymes that would have actually degraded the cell upon its death. How does that happen? When the cell dies, the membranes will become very actually porous, right? One of the membranes that will become very porous is going to be the lysosomal membrane. So those enzymes from the lysosome will take care actually of degrading the dead cell. Now, what happened as a result of the acidity that has set in, those enzymes are not going to be able to do their job. Why? Because they don't have the optimal pH at which they work. And as a result of that, the cell will actually stay standing. So if you look at the structure, you will think that the cell is still alive. But if you look deeper into the cell, you will see that there are no nuclei anymore. And you will look at the cytoplasm, and you will see increased redness of the cytoplasm, as we have discussed in a second ago. Now, this is seen with hypoxia and with, that is emanating from ischemia. It could be seen also with heavy metal poisoning and irradiation. All right, and where do you see it usually? You see it usually in solid organs. The reason for this, with solid organs, there are actually strong support structure that will be able to let the cell stand out for a while after they die, okay? Whereas, if the same process, such as, would you kindly give me the
Sure.
first one, please?
Sure.
Thank you.
No problem.
All right, if the same insult, which is ischemia or heavy metal or irradiation, so those are going to give rise to actually coagulative necrosis when they happen in solid tissue. If the same processes, if the same three processes happen, let's say in the brain, the result will not be coagulative necrosis. The result will be liquefactive necrosis. There are two reasons for this. Number one is that the brain is a weak structure compared to the heart, compared to the spleen, compared to the kidney, right? So this is number one. Number two, it's going to be actually that this brain is rich in lysosomal enzymes. The brain material is rich in lysosomal enzymes, and which upon actually this insult will be released, and they are going to overwhelm the acidity that may have set in, and it's going to liquefy that part of the brain. So the end result of that is going to be liquefactive necrosis rather than coagulative necrosis. All right, so infarction is actually a form of a coagulative necrosis resulting from ischemia. So it is actually, think about it, it is a piece of tissue that is dead, but it is still standing. Now, this is actually a temporary stage. It will not last forever. And we will talk about why it does not last forever. Right. Talk about this. Right. So how will actually coagulative necrotic tissue looks like? So dead tissue, but it is solid. Remember that. That's really the most important word when it comes to the description of a coagulative necrotic tissue. It is firm. It is not soft. All right. At least, again, for a while. And the reason why I'm saying for a while, because eventually everything is going actually to go and become liquefied. Okay. So the cell may actually opt to chew or opt to die by coagulative necrosis, or is put to die by coagulative necrosis. But this process will not actually stop at this point in time. The reason for this, let's talk about the heart, for example. So there is an area that you can see, obviously this guy have lived long enough after the insult to reach the stage where when you look at the heart, you will see gross morphology. And gross meaning you will see it with your naked eye in the wall of the ventricle, as you could see here. Now, when you take a section of this, let's say that you take a section of this area right here. You take a transverse section of this area. What you're going to be looking at, if you recall from yesterday, the first area, zone 1, is going to be the area that is most close to the coronary artery supply, right? It's going to be still, somewhat intact. Now the area, that is close to it, zone number 2, is going to be reversibly damaged, right? And the area that is most distal to it is going to be the zone 3. That's going to be completely dead. Now, if you look at the zone 3, you will see that the cells, look still standing, right? For the untrained eye, you may actually call it normal. But if you look at, the redness of these cells compared to these cells, you will see it is more red than actually these cells. This is number 1, the cytoplasm. 2, you look at the nuclei, which is the most solid evidence, and the nuclei are missing. So you are looking at an area of a coagulative necrosis. Now, I keep telling you that actually this area is an area of, actually, it's going to be there only temporarily. And the reason for this, it cannot stay there. The organism is going to change it. Why does the organism change it? The organism changes it because it's a weakened area. Imagine this is a very dynamic structure that is beating so many per minute. And if you keep a weak area like this, perforation will happen, right? The wall is going to give way. It's going to simply perforate. It will not take this dynamic, movement of the left ventricular wall. And as a result of that, this area is going to be removed. Okay, so coagulative necrosis is going to turn eventually into liquefactive necrosis. How does that happen? That is going to happen when the inflammatory cells that will be wheeled to the site of action, which will happen, one of you say inflammatory cells, to see it. That's usually going to take about 8 hours, or so, 6 hours and upward of that. So within 2 hours, you won't be able to see that. But if the person lived long enough for that to happen, inflammatory cells will be wheeled to that site of action, of damage, if you will. And those inflammatory cells are going to be neutrophils, or first neutrophils and then macrophages. Neutrophils will do what they do best, which is detonation. They are going to release their contents, and their contents are degradative enzymes. So these degradative enzymes are going to come and simply degrade this area. You see that? This area will be degraded, it will liquefied, if you will, right? So the neutrophils, how do the neutrophils come to the site of action? How does that happen? By what? By cytokines, someone said. Right, and where will these cytokines and other factors are going to be released from? By actually the dead myocardial cell themselves, right? Or if there is any kind of a transient inflammatory cells within the myocardium, this is what you call a standby cell, will also play a role actually in inviting these neutrophils first. So the neutrophils will come, liquefy, then the neutrophils themselves will produce more cytokines and more growth factors that are going to invite the macrophages, right, to the site of action. The macrophages are the scavenger cells, right? So they will come in and they will take up this cellular debris. And the macrophages themselves will produce further cytokines and further growth factors, such as the PDGF, the FGF, the TGF. All of those are going to recruit at this stage. They're going to be recruiting the fibroblast to the site of damage, and they are activate those fibroblasts. Fibroblasts will come in, they will organize, and they will form a fibrous scar, right? Because this is a permanent tissue, right? There is, unfortunately, you will not have myocardial cells here. But that's better than nothing, right? Better than dead cells, correct? If you leave dead cell here, that's going to be disastrous. So in this case, the organism actually decided to switch from the dead cells to a fibrous scar. It's going to be much better to live with a fibrous scar than to live with a dead myocardial cells. All right, so now liquefactive necrosis. Someone is buzzing me, I apologize for that. All right, so liquefactive necrosis. In this case, what you are going to be looking at is simply no cellular boundaries. You look here, and you still see the cellular boundaries, the cellular structure, architecture, if you will, right? Or what is known also as the cellular silhouette. Silhouette, I don't know how that is translated into Arabic, to be honest. I can understand it, as, probably as the, something that is still standing, but it is really dead, someone like a khayal, probably, khayal something, if that makes any sense to you. All right, whereas here, you simply have absolutely no cellular cellular silhouette or cellular architecture still standing. Liquefaction means what it means. It means actually complete degradation of all cellular, structures. There will be only left cellular debris and inflammatory cells in that site of action. How does that happen? It happens again by enzymes, either the cell's own enzymes or actually enzymes that emanate from inflammatory cells, such as neutrophils and macrophages. So where do you see it? With bacterial infection, sure, because there are inflammatory cells that will be wheeled to the site of action, right? As I mentioned to you, where else would you see it? You see it after coagulative necrosis, because coagulative necrosis will only be a transient stage, and then eventually everything will be liquefied and taken out. Now, you may see it from the get-go. So it's a matter really of time. In some structures, such as the brain, if infarction happened, you won't start with coagulative necrosis. You're going to start with liquefactive necrosis right off the bat, from the start. And gross appearance is going to be, necrotic area. When you touch it, the most important thing is going to be soft to the touch. Remember that. That's a very important indication that what you are dealing with is liquefactive necrosis. Now look at the microscopy of these areas here. So this is actually lung abscesses happening as a result to lung abscesses here. So the lung abscess is a walled, form of a chronic inflammation. The tissue was not able to deal with that inflammation. It was not able to resolve the inflammation. And in order to prevent actually the spread of that inflammation, the immune system will react to it by simply trying to wall it off from the rest of the structure. That's exactly what happened here. So two areas, where you see lung abscesses. If you take a section of those areas, you're going to be seeing a simply sea of debris, and probably fewer inflammatory cells here and there. So look at this. So you will see no cellular outlines whatsoever, but you may see some inflammatory cells such as the newts, and probably if you look around, you will be able to see also some macrophages in the surrounding of this area that is liquefied or necrotic. Now that's a beautiful example actually to compare for the two processes in the same organ. The organ is the kidney. The first on the left is actually a kidney that is affected by ischemia. And as a result of the ischemia, coagulative necrosis is going to set in. You look at these cells and you will, for the untrained eye again, it looks standing, right? It looks there. So you may actually confuse it that it's still somewhat normal. In reality, if you look at the nuclei are no longer there. So this is dead tissue for sure. You look at the redness of the cytoplasm, and the cytoplasm is pretty red. Now, as I told you, this is going to be only transient. Eventually, this is going to give way for liquefactive necrosis. It will not stay there, longer. Now, if you look at, this picture right here, this is a kidney affected by an infection. So the infection, there are inflammatory cells that will be wheeled to the site of action. The inflammatory cells will release, the neutrophils will be releasing their contents, the degradative enzymes, that will liquefy the area, okay? Will simply liquefy everything, tissue and the bugs, the organisms that were invading or infecting that, kidney. Eventually, what you're gonna be seeing is sea of cell debris in addition to inflammatory cells right here in the vicinity of the process. All right, so now we have talked about coagulative necrosis and we talked about liquefactive necrosis. And coagulative necrosis is firm, right? Firm with a standing structure, correct? Whereas liquefactive necrosis is soft and loss of cellular outlines completely. Now, caseous necrosis is going to borrow features from both. So caseous necrosis is a form actually of liquefactive necrosis. So if you take a section of a tissue that is affected with caseous necrosis, caseous means cheese-like, remember that. So it looks like cheese. Unfortunately for pathology, we use a lot of what you call food names when you describe some horrible diseases. This is one example of that. So cheese-like, and we will talk about where the cheese-like material comes from in a second. So if you look at a tissue that is affected with caseous necrosis, you will see that it is actually, it is, completely, the cellular outlines is completely gone. But if you touch it, if you touch that structure, you will see it actually form. So it's borrowing from liquefactive and borrowing, from the coagulative necrosis. So where does actually the firmness that is seen with this form of liquefactive necrosis coming from? It comes from actually from the granulomas, because the caseous necrosis is a form of a chronic inflammation, especially with fungal organisms, especially with mycobacterial organisms. When they infect tissues, the end result is going to be a form of a chronic inflammation known as a chronic granulomatous inflammation, where you see the formation of granulomas. These granulomas are like what do you call it, nodules, and to the touch it feels firm. Actually, this is where the firmness of the caseous necrosis comes from the nodules, from the granulomas that are seen in this kind of necrosis. So where does the cheese-like material comes from? The cheese-like material is actually the lipid that comes from the walls of the fungi and the mycobacteria that have died in the millions in the process of infecting that tissue as a result of the inflammatory response to that infection. So the end result is going to be those organisms will release their lipids in this tissue, and this lipid is going to be so rich it will look like a cheese-like material. All right. So if you take a section of these areas, look at this. This is an example of a caseous necrosis, and the caseous necrosis here is happening in the lung in the form of what is known as miliary TB, miliary tuberculosis. Okay. So it's a form of a mycobacterial infection, miliary tuberculosis. The name miliary comes not military, miliary. Miliary is from millet. You know what millet is? Anybody from India here? Millet. It's a form of seed, right? It's a form of a spice that is used in food. Again, pathology actually resorting to food to use, for some horrible processes. So what you're looking at, you're looking at these nodules that are spread within the lung. Each one of these nodules is a granuloma. Okay, remember that. So when you touch this tissue, which for all practical purposes is a liquefactive necrosis, it will not feel soft to the touch. It will feel rough. It will feel firm. And the reason for this are these granulomas that are spread throughout the lungs. And when you look at this, you will see what I mean by the granulomas. So first, you will see the liquefactive necrosis with absolutely no cell boundaries. As you can see here, you cannot discern any cell that is still standing because simply the neutrophils have done their job and liquefied everything. Now, in the vicinity of this actually intense, destruction, you will see these structures, the nodules, the granulomas that I talked about. You see these cells, and the cells in the vicinity are what you call actually the cells of granuloma. These are the giant cells of granuloma. In the case of a fungal infection, it's going to be called Langhans. In the case actually of a mycobacterial infection, it's going to be called Langhans giant cells, where you see that the nuclei of the giant cells are going to line up, against the periphery of the cell. And then the star action of these cells will be what you call the activated macrophages that will take an epithelioid shape. Another name for it will be epithelioid histiocytes that are going to be the site, that are going to be the star cells of this process. Here is an example of that. This is actually the horseshoe of the Langhans giant cell right here. It looks like a horseshoe, as you can see here. And then nearby, you see these kidney-shaped, cells. These kidney-shaped cells are the activated macrophages that, as a result of their activation and involvement in the process, have taken up the shape of an epithelial. It took out an epithelial shape. That's why they are called epithelioid histiocytes. Now, in the vicinity of all of those, also there is the chronic inflammatory cells in the form of lymphocytes that are present here. The collection of this is going to be called a nodule. It's going to be called a granuloma. That's what gives firmness to the caseous necrosis. Fadala. Can you speak up, please? at microscopically, you will not see with liquefactive necrosis the granulomas. Yeah, which is this structure right here, exactly. All right. All right, so let's continue. All right, so now we talk about enzymatic fat necrosis. So in this case, what you're looking at actually death of fat cells. Death of fat cells happens in a couple of ways. One of them is by enzymes. And the second one is going to be actually as a result of trauma, as a result of the usual garden variety, actually, cell necrosis. We'll talk about enzymatic fat necrosis first. When you talk about enzymatic fat necrosis, more or less, you're talking about actually the peripancreatic fat tissue. That's really the best example that you could find around for this kind of death of fat cells. So the peripancreatic fat tissue, what happens actually during acute pancreatitis is that there will be activation of the pancreatic enzymes, of the pancreas within the pancreas itself. So instead of actually all the enzymes kept in a zymogen-like, state in the pancreas and get activated at the brush border of the, duodenum, in the case of acute pancreatitis, those enzymes are going to become activated within the pancreas itself. And that is going to result in destruction of the pancreas itself and also of the peripancreatic fat tissue. The end result is going to be the fat cell necrosis that we are talking about. So what happened here is that as a result of the lipases and the amylases that are going to be released from the pancreas activated, it will break down the triglycerides of the fat, resulting in the formation of fatty acids. Fatty acids will combine with calcium via a process known as saponification, and this actually calcium and fat acids structure are going to start to get deposited in the fat cells, and that's why actually it will give it it will give rise to the calcified deposits that are seen in the mid upper abdomen in acute pancreatitis. All right, so when you look at this, you will see those deposits in the mid upper abdomen. In this case, the more actually deposits you see, the more hypocalcemia the patient is going to be suffering from. So this is one indication about the severity of the process of acute pancreatitis in those patients. And when you look at microscopic, appearance of those, dead cells, you will see again pale outlines. So in a way, actually, the cells are still standing for a while, and you will see it also filled with this bluish material. The bluish material are simply the calcium deposits that when stains with the H&E stain, it will pick the hematoxylin stain, similar to what you see with the nucleus. And as a result of that, it will give rise to this bluish color. So the bluish color comes from the fat salts that have joined up with the hematoxylin, that taken up the hematoxylin and showed up as a basophilic, showed up with a basophilic appearance. So here's an example of that. If you look at the pancreas itself, you will see that there are nodules. These nodules are actually nodules of calcium that are getting deposited in and around the pancreas and the peripancreatic fat tissue. You take a section of the pancreas, and what you're going to find actually is that there are areas within the pancreas that are completely gone. So that's a form of liquefactive necrosis, correct? The enzymes of the pancreas will wreak havoc on the pancreas itself, and it's going to simply liquefy those structures within the pancreas. So where the release happens, if you look down, you will see only cellular debris. Now, if you look in the nearby tissue, you will see that the structure is still standing somewhat. So in this way, you are seeing really two forms of necrosis in the same picture. A liquefactive necrosis, which is really what's happening at the level of the pancreas as a result of the activation of the pancreatic enzymes within the pancreas. And then on the outside, you're seeing actually a form of a coagulative necrosis, in the peripancreatic tissue. And the coagulative necrosis is happening because of the fact that in addition to the fat cells, you now have calcium salts getting deposited as well. And it's a form of dystrophic calcification, actually. Usually when injured tissue, happens, they attract calcium to them. And that happens pretty much everywhere in the body. In this case, it is happening at the level of the pancreas. So this bluish color, all the bluish color that you see in these dead cells, why do you call it dead cells? Because if you compare it to normal, with the normal, you see this peripherally located nucleus in each one of those cells. Look at this nucleus here, or the nucleus here that has been, bumped to the side with the lipid globule, if you will. Now, if you look here, you will not be able to discern any kind of nucleus in these cells, right? So these are dead cells, and add to it, this calcium that actually have kept it, gave it structure at least for a while, as you could see here. So all this bluish basophilic staining is actually calcium. Now, that's actually one form of fat cell death. The other form is simply going to be what you call the garden variety of cell death. In this case, for example, following trauma, such what happened, for example, to people with pedunculous breast, for example, as a result of the trauma to those tissue. Again, you're going to see what happens elsewhere in the body. So in this case, the necrosis will happen as a result of the inflammatory cells that will be wheeled to the site of action. Inflammatory cells will be releasing their content. So what kind of necrosis will happen in this case? It will be liquefactive necrosis as a result of the release of the enzymes from the neutrophils that will simply liquefy everything, resulting in liquefactive necrosis that will eventually heal by scarring. So eventually, as you will see in the next few lectures, by the other people in pathology, you will see in the repair process will entail the arrival of fibroblasts to the region, organizing of those fibroblasts in the form of a fibrous scar that is going to replace the tissue that has been damaged. Calcification may also happen in this case, again, because it is injured tissue that will invite calcium to it, resulting in what's known as dystrophic calcification. All right, fibrinoid necrosis, it's a form, obviously we'll not be able to finish today. So in this case, I would ask you actually to give me an hour, an extra hour anytime, before the beginning of the next pathology lecture, okay? We'll do it online. We don't need to do it here, actually, okay? And I will ask, one of my great TAs to be with me, in that hour, to also, coordinate that lecture. So just let me know, anytime from now until the start of the next block, we can sit and do the rest of it. So what do you see in fibrinoid necrosis? Fibrinoid necrosis is an immunological injury. In this case, you have actually a form of immune complexes that are either circulating, what you call circulating immune complexes, or immune complexes that are forming in situ, in tissue. And as a result of that, there will be activation of the complement. It's a type 3 hypersensitivity reaction that is going to result in destruction of the tissue in and around that area. It is known to be, present with, small vessel vasculitis. It also could be seen with rheumatic fever in patients with rheumatic heart disease vegetation that's actually resulting from this immune, mediated injury. It could also be seen with the pannus in rheumatoid arthritis, the inflamed synovial tissue that you could see in rheumatoid arthritis. So what happens simply as a result of the deposition of these immune complexes everywhere in the tissue, the end result is going to be a tissue injury in and around the region. So that could be in the form, this tissue could manifest itself in the form of, vegetation that you see with rheumatic heart disease, in the form of rheumatic nodule that you may see with, rheumatoid arthritis, and in this case with vasculitis, inflammation within the vessel walls that you see with small vessels disease. So there is so much deposition of this immune response, of these immune complexes within the vessel wall. The vessel wall will give way. It becomes very porous. As a result of that, you see the plasma have gone out of actually this vessel wall into the vicinity of it. This is why you see this very brisk inflammatory response in and around the vessel wall, okay? The poor vessel is simply, is simply leaking in a way as a result of this immune-mediated injury. And you see a lot of inflammatory activity within the vessel wall, as you could see. This is where the name vasculitis come from. Where does the vasculitis come from? Again, as a result of the deposition of those circulating immune response. So it could be, this immune complexes could be either, circulating, so it could have formed somewhere else, and now it is in the blood and going in the flow, or it could actually form in situ. So let's say that actually there is a self-antigen that was hidden, and somehow it became actually uncovered. Similar to what you see, for example, in an injury in the lung known as the Goodpasser syndrome, where you will see that it's going to be preceded by a viral infection that is going to unmask certain epitopes that usually are hidden from the immune response. When those epitopes will be exposed to the immune system, they are going to be interpreted as other antigens. And as a result of that, the immune system will mount an immune response to them, resulting in formation of an immune complex in situ. So autoantibody directed against the self-antigen, resulting in the formation of immune complexes in situ, as opposed to the circulating immune complexes. The end result is going to be tissue destruction, regardless of what form of immune complexes it is. All right, what time is it? It's not. All right, so I still have 10 minutes. Yeah. You stop at 10:50 or do you do?
Whenever you're ready.
Yeah, let's stop. We have to take actually another hour, so it doesn't matter. Maybe. All right, any questions? Further.
When we see the fibrinoid necrosis, how can we differentiate between it and liquefactive necrosis inside?
Right, it is actually a form of a liquefactive necrosis. Absolutely. Now, would you be able to differentiate it? Actually, then at this stage, clinical history will matter. Then there is also serological, studies that you could do, that is going to give it out. You may do some immunostains that will give it out. So there is a long list of things that you will do, what you call ancillary kind of studies that will give it out, as opposed to, your like bland, liquefactive necrosis only. So there is more to it. You need to look at, you may do actually the complement, components serology. You may look at the levels of the complements in the blood, and you will see it decreased. Why? Because it has been used up in this process. So there is a long list. You may look again at the autoantibodies that are actually maybe circulating in the blood. So that may give it out as well. Different kind of autoantibodies directed against different tissues that the patient may be coming in, and you may be able to elicit that in the clinical history. So clinical history studies that are going to tell you exactly what the patient is suffering from. Further. But would you please speak? I have a problem with my hearing, yes.
I have a question about the nodules. I remember you said in a previous lecture that yellow nodules are related to cancer, right?
This is actually exactly, this is in the prostate, yes. Right, because the prostate cancer actually, it's the prostate cancer cells are known to be cells that are very rich in lipid. And lipid in tissue usually will take the yellowish color.
Like, why don't we have yellow nodules in
Enzymatic fat necrosis, right? Well, enzymatic fat necrosis in the pancreas. The nodules that you see actually in the pancreas are white because they are calcium, and calcium usually grossly is white.
But why don't we have
Lipid. I don't know the answer to that, but probably you have some actually. You may not be able to like see it right away, but let's see. Let's see. Actually, you know what? This is fat probably right here. Okay. So fat tissue, the fat tissue itself, because the fat tissue is taking up the calcium. And when it takes up the calcium, it will no longer actually project itself as fat, but as like in a way actually really, if you want to call it calcified fat, which is going to take the white color, if you will. All right, so the yellow color will be obscured with the white calcium that is going to set in. All right, anything else? How about?
Yeah, doctor, we have a couple questions. So liquefactive necrosis.